Okay, so part 2 of our BST biopsy unknowns. I just wanted to let everybody know that hopefully you all got the Chicago Past Society Boards Review lecture recordings from last fall, but I know that there's like hours and hours and hours of lectures. So what I did was I separated out my head and neck, and my bone and soft tissue review, which does include all head and neck and thyroid and all bone and soft tissue. So I put it on my YouTube channel because I don't think I have my like general BST stuff recorded. So this is a very condensed version of it. It's like maybe an hour of head and neck and an hour of BST. But hopefully if you need a refresher, you can just go and view that. So I just wanted to mention that. Okay, so the other thing I wanted to mention was we added one slide from one of last week's cases, and that was case 4, which was the woman with myositis ossificans. And so just as a reminder, this was her core biopsy, right, which had this sort of nodular fasciitis-like appearance, but focally with bone, and certainly ossification on imaging. And so after a while, she did undergo resection, which we don't see very often. And her specimen was essentially a shell, a very large sort of shell of bone. And so here with kind of cystic degeneration in the middle. So as you can see here, we have this shell of bone. And as myositis ossificans matures, as it did in this case, I mean, she didn't really undergo treatment as far as I know. The bone sort of progresses to this much more mature lamellar bone at the periphery. You maybe see a little bit more woven bone in areas with a little bit of loose fibrous tissue. So just remember that, myositis ossificans can mature. In this case, on the resection, it was very, very bone rich and sort of, fibroblast poor, but that's okay, that happens. So I just wanted to share that with everyone because we don't really see these resected very often. So it's going to be in this presentation. After today, after we've done all 10 cases, I will send out the link to this full presentation with the IHC and with the resections, as well as, of course, the recordings will be on the YouTube. So if there's no questions, we're just going to now continue with case 6, which is a 49-year-old male with a history of clear cell renal cell carcinoma with a soft mobile right thigh mass. All right, Heather, you want to talk about the imaging?
Sure. So I popped in I popped in 3 like adjacent cross sections from his MRI, and you can see on T1, you can see that it's got like this very well circumscribed lesion in the middle of the muscle, kind of like nudging right up on the bone right here, but not really like invading it. And it's very hypodense on T1. It's very nice and kind of like fluid intense on T2. So like you can tell it's a very like fluidy kind of thing because it's very bright on T2. And there's only kind of like minimal enhancement kind of around the edges on contrast. So I don't know, together these findings are consistent with something like fairly benign process. And you could suspect, if you look at something and it looks like this, you could suspect something like myxoma.
Awesome. So, of course, anyone with a prior history of cancer, we have to exclude the cancer, right? But based on those imaging findings, it's a well circumscribed, low grade appearing thing with maybe a gelatinous signal. So anybody want to take a gander at this guy?
I could describe it.
That'd be great.
Sorry, my screen is disappearing here. Right, so we have kind of at low power something that matches up nicely with the imaging, that kind of myxoidy appearance. Excuse me. And then we have these spindly cells that are kind of percolating throughout that myxoid background. They have maybe somewhat wavy nuclei. There's some pinkish collagenous looking material, maybe shredded carroty looking material. I don't know. Kind of in the background as well. I don't think I saw many mites on this one. Here it's a little bit busier looking, but again, it's pretty consistent throughout. I don't know if there are any other features that I might have passed over.
Yeah. So no, that's good. So Reham's adding maybe some thin-walled blood vessels, certainly. Nothing very strikingly vascular, but yeah, some small capillaries and some small vessels. Basically agreeing with what you said with these kind of spindly cells set in this variably myxoid to collagenous stroma, with, you know, maybe a slightly larger nucleus here and there, but really nothing that's angulated, hyperchromatic, and large, mitotically active. So then what would your sort of, you know, anybody can answer or type, what would your differential diagnosis be based on this histologic features of the core?
I was wondering maybe like something in the like neurofibroma, but although it doesn't really, I think, fit that particularly well.
Okay.
Yeah, I think I was convincing myself that I saw like shredded carrots, quote unquote, but I don't actually, looking again at this, I'm not quite sure that that would have been the best.
Got it. So yeah, so myxoid nerve sheath tumors should certainly be very high on your differential for bland looking spindle cell lesions, because it's an easy thing to kind of consider and rule in, rule out with your immunostains, right? And so even though the nuclei here aren't perfectly sort of wavy or buckled, arguably there may be a little more oblong and ovoid, but you know, a nerve sheath tumor will be something to consider. So to rule out nerve sheath tumors usually enhance really brightly on imaging too, for what that's worth. And this was not, or was enhancing.
That barely had any enhancement around the edge.
Oh, that was the one with the, okay, got it, cool. So that would be the T1 plus contrast, got it. Okay, so yeah, so an S100, right, or a SOX10 would be quite easy to rule out something that is of Schwannian origin, and this particular one would be negative. We have myxoma and angiomyxoma. So Reham, tell me, or Heather, the difference between an angiomyxoma and a myxoma.
So I think angiomyxoma, we would have curvilinear blood vessels. That's my understanding. With myxoma, I'm not sure if we are able to see blood vessels.
Mm-hmm. I mean, most tumors need vessels just to survive, right? And so you are generally going to see some vessels in all tumors. In this case, they're more small capillary-like vessels, right? So you don't, I agree though that you don't really see the very characteristic sort of, you know, curvilinear, you know, chicken wiry type vessels of a highly richly vascular neoplasm. But what's the other difference in this case? Do you expect to see angiomyxomas?
No, no. In the muscles, it would be more, I think, intramuscular myxoma.
Right.
Yes.
So where do we normally see angiomyxomas?
I think GYN tract, like vulva.
Okay.
Like angiomyxoma superficial or deep, I remember that. And for,
okay.
Where else? I'm not able to remember.
Yeah, so, okay. Anybody else have any comments on angiomyxoma? Just so we can get that out of the way. So there are deep, aggressive angiomyxomas that are in the GYN area, right, or pelvic area, that are highly infiltrative, that are richly vascular, that have vessels of varying sizes, and often a hybrid sort of collagenous to myxoid stroma, not really in the peripheral soft tissues, all right? Then there is the superficial angiomyxoma that are these sort of cutaneous like lesions of the digits, etc., that are very much like sub or ungual peridigital type of things that are a whole different sort of ball game. Again, not digitus, not in the deep intramuscular soft tissue. Okay, there is just while we're here, there is a soft tissue, a deep soft tissue angiofibroma, okay, which could be in this type of location, but may again be more richly vascular, not really have quite that much myxoid background that we're seeing here, right? So I think we can exclude kind of these things in the differential and go back to what was typed in the chat, which is myxoma. So is there anything immunohistochemically that will help you prove a myxoma? Not really. So if you're thinking to exclude a nerve sheath tumor, yeah, you can say it's S100-SOX10 negative. If you're thinking to exclude a carcinoma, melanoma, sure. But otherwise, like, these are basically kind of non-specific immunohistochemically. They may have a little CD34. They may have a few histiocytes in them, so have some CD68, but nothing strong or nothing consistent with these actual fibroblast, myofibroblast type cells, right? They're just sort of nondescript diagnosis of exclusion. So this is the resection specimen, just a classic intramuscular myxoma. There's skeletal muscle at the periphery, and there's these nice kind of monotonously very paucicellular areas with curvilinear sort of nuclei and myxoid background. What might be the one other tumor that we haven't talked about yet, but now that we see the resection with occasional interspersed more fibrous, right, more pink bands, what is the one other diagnosis that we may want to exclude with this morphology that has both myxoid background and occasional fibrous septae or fibrous background, collagenous background, I should say?
Like a low-grade fibromyxoid sarcoma? Is that what yeah.
Exactly, right? So a low-grade fibromyxoid sarcoma would have pretty hypocellular background like this with these discrete zones of fibro, collagenous, and myxoid, exactly. So usually those patients are a little bit, sorry, where was I? Usually those patients are, no, this is an okay age. Usually they're like 30s, 40s, 20s, even extremities. And so in that case, what immunostains would you want to do to exclude a low-grade fibromyxoid sarcoma? Okay, MUC4 and?
Yeah.
MUC4.
Yep, one more you could consider.
I don't know. I don't know.
Yes, Ryan's got it, EMA, right? So usually I do both because sometimes one is better than the other. But yes, low-grade fibromyxoid sarcoma would be MUC4 and EMA or EMA positive, and just a myxoma would be MUC4 and EMA completely negative. Okay, so that is additional. I can't remember, Heather, if we did those stains on the biopsy, probably.
Yeah, I think they were negative.
Great, good. Okay, questions or comments? Yeah, CD99 not so helpful for this particular differential. All right, case 7. A 63-year-old female undergoing workup for liver transplant with an incidental left 6th rib mass. All right, so don't you love how we find all these things completely incidentally when we're being worked up for other things? So why don't you go ahead and describe the imaging?
Oh yeah, so here we've got like a nice cross section from a chest CT. You've got like the heart over here, lungs over here, obviously, and in the 6th rib over here on the left side, you see this kind of like lytic lesion that appears to be buckling the bone, and this has a fairly broad differential that ranges all the way from like like either a giant cell rich lesion or like some kind of, or something along those lines, or it could, or of course you want to like exclude the possibility of some kind of metastatic cancer too, although that's a little bit less likely.
Cool. Hold on one second. Let me just pull up my. Oops. All right. Okay, so here is the core.
I can try.
Thank you.
I actually just reviewed it like 2 minutes ago.
Good.
So on a lower power, we see some like extravasated blood, and then we see like these cellular areas, and like with this two elements present in a core or in a section, there are certain things that basically comes into your brain. That two of them is one is ABC, the other one is a giant cell tumor, because all of these are like a lot of like look like giant cells are there. And the other possibility could be myositis ossificans, but I don't see.
Are we in the muscle?
Yeah, no, we are not. So, but first of all, we are not in the muscle. So I still think, because ABC doesn't like those pools of blood that the cystic spaces don't have a lining around them, and in a core it's hard to tell if it's like a these are actually cysts or these are this like extravasated blood. But I think a USP6 rearrangement defines between, can differentiate between these two, but these are like this is my very crude description and my two top differentials for this one.
Yeah, so I think aneurysmal bone cyst is an excellent thought with blood-filled spaces, with stromal-rich areas that are rich in giant cells, as well as these kind of background spindly cells. Now, what in this particular field, what is kind of missing? ABC can be present in any bone, any bone. So yes, face, ribs, long bones, any bone. What is different than, what is missing here that you might expect to see in a true giant cell tumor of bone? I mean, what is different?
Would there be more giant cells?
So there may be more giant cells. There may not be more giant cells. The answer's in the background. What's different about the background cells here than a true GCT?
Aren't they supposed to look more similar to the giant cells?
Right. So the mononuclear cells in a giant cell tumor of bone are actually much more plump, and the nuclei sort of resemble the nuclei of the giant cells. In this case, the background cells are much more spindled and kind of almost vaguely storiformy in architecture. And so it's essentially the shape and the morphology of those background cells that can help you differentiate. So, you know, yes, they say that giant cell tumors of bone have very evenly spaced out giant cells, have lots of giant cells. The giant cells in them have lots of nuclei, but the neoplastic cells are the ones in the background, and those are the cells that are different, right? So the cells of a GCT, again, are going to be more plump, and these are a little bit more spindled. So, all right, and so you correctly said that if you were thinking that this was aneurysmal bone cyst, you could do USP6 gene rearrangement, which actually, I don't know if it was done. No, it was not done in this case, because there was some additional, perhaps clinical information that was making this diagnosis different. Heather, do you want to tell us about the clinical?
Oh yeah, so this lady had a history of like hepatorenal syndrome essentially, and so thanks to her kidney disease, she also had secondary hyperparathyroidism.
So the thing that we don't always think about, because we don't often see it biopsied, but looks exactly like what you might see in an aneurysmal bone cyst, is brown tumor of hyperparathyroidism. Yeah. So in this case, we would expect USP6 gene rearrangement to be negative. As I said, I don't think it was performed on this case, but in the setting of hyperparathyroidism and bone disease of hyperparathyroidism, you can get these aneurysmal bone cyst-like, right, lesions, so-called brown tumors, okay? And so I have another example of the exact same diagnosis in a completely different patient. But I want to show you that this actually has a little more characteristic features. Unfortunately, in the one we showed you, we don't have much pre-existing bone. But if you are lucky enough to have pre-existing bone, what you do see in the setting of hyperparathyroidism is this, let me see, it might be better on the other core, is this extensive or excessive, yeah, there it is, osteoclastic resorption of bone. All right, so you see these house-shaped lacunae, or these sort of pits where the osteoclasts are eating up the bone. And then you see on the counter side, osteoblasts trying to deposit the bone to try and keep a little bit of a steady state, right? But because this patient is hyperparathyroid, the PTH is just basically destroying this bone by activating these osteoclasts to resorb the bone, which you can see very nicely here. But your bone is trying to compensate by replacing more at the opposite edge. So this picture, adjacent with osteoclastic resorption and osteoblastic deposition, with a kind of very fibrous cellular marrow, is characteristic of renal osteodystrophy. But then as you move, that's just marrow. As we move to the actual lesion in this case, you can see that it looks nearly exactly like that prior case and nearly exactly like an aneurysmal bone cyst, right? Where you have giant cells with intervening spindly mononuclear cells with blood-filled spaces, and with this very kind of collagenous fibrocellular stroma with, the brown, right, coming from the hemosiderin, coming from the hemorrhage, coming from the pools of blood, okay? So again, this would be a case of USP6 negative, but you have to correlate with the clinical of hyperparathyroidism brown tumor. So a great example, because we don't see these very often, but keep it in the back of your head if you see something that may be ABC-like, but it's USP6 negative and the patient, think about the patient having hyperpara. Questions? Could we consider fibrous dysplasia on the histology or on the radiology?
Histology.
So
could we see giant cells, a lot of giant cells in fibrous dysplasia?
Only if it has secondary aneurysmal bone cyst-like changes.
Okay.
So ribs are a great place anatomically for fibrous dysplasia, with this bowing out of the rib with a kind of ground glassy appearance. So the location will be great for fibrous dysplasia. But if you don't actually, so fibrous dysplasia is a fibroosseous lesion, right? So you should see osseous, right? You should see bone, and you should see very monotonous intervening fibrous tissue between the bone without giant cells. The only time you're going to see giant cells and blood lakes in fibrous dysplasia is if you have secondary ABC change. And if you have that, you would want to see some evidence of fibrous dysplasia in the background, right? Otherwise, you're never going to make a diagnosis like either way.
Understood. Okay.
Okay. Awesome. Other questions? All right, case 8, 66-year-old male with history of CLL and metastatic PTC with new lytic T12 lesion. All right, so could be CLL, could be metastatic disease. Heather.
Oh, yep. And here it could be consistent with like basically anything. I have like the bony windowed CTs here. Like if you're going to look at bony lesions on CT, you should definitely window it for bone. And in the sagittal, you can kind of already see, here we go. In the sagittal, you can already see here at T12, you can see this kind of like area that looks like somebody took a bite out of the vertebral body with a little bit of kind of like a reactive sclerosis around the edge. And when you look at it in the axial section, you can see that it also involves some of the spinous process and some of the other posterior elements like the lamina as well. And here too, this has like a pretty broad differential, you could totally think about like an aneurysmal bone cyst, or a little bit less likely, you could think about fibrous dysplasia. You could think about a metastatic lesion. Unfortunately, this one didn't have like an MRI that would have maybe shown us whether there were fluid levels or something like that.
Cool. All right, so here's the histology. Who's gonna at least describe what they see?
I could try.
Okay.
Okay, so I'm seeing bone trabeculae
Mm-hmm.
and the intertrabecular space is filled with kind of fibrovascular tissue.
Mm-hmm.
And I think the vascular component is prominent.
Mm-hmm.
So it's like dilated, dilated capillaries maybe.
What other component is prominent?
Loose fibrous tissue, or yeah. I'm not sure if I'm seeing any kind of osteoclast or.
So those are osteoblasts. There's maybe an osteoclast.
Yeah, osteoblast. Yeah, the trabeculae, it's rimmed by osteoblasts. They look so, yeah. And
Yeah,
here
it's a little, you have to kind of look around to see them, but you know, they're
they are
there.
here. They are here. And we have osteoclast as well.
Mm-hmm.
So,
Okay.
so the differential here, osteoblastoma maybe, and
Okay.
it could, I think it could present in the vertebra.
Absolutely.
And I'm not sure if osteoma could enter in the differential diagnosis. I believe osteoma should present in long bones, and I'm not sure about this. And the side, as I remember, the side would play a role in the differential diagnosis between osteoblastoma and osteoma. But I would put osteoblastoma number 1 in my differential diagnosis.
Okay. Yeah, so osteoblastoma and osteoid osteoma are differentiated mostly based on size, like you said, with osteoblastomas being bigger, basically 2 centimeters-ish or more, and osteoid osteomas being smaller, usually with a sort of central nidus and a peripheral kind of more cellular, I got a bony rim, and night pain, right? So osteoid osteoma, smaller, nidus, night pain, treated with NSAIDs. Osteoblastoma, larger, usually not the same clinical picture of night pain without that NSAID association. Okay, so right, clinical and size features. I believe this one was somewhat larger. So we're not thinking osteoid osteoma. As you can see, there is no central nidus either. It's just basically all pale. So osteoblastoma definitely on the differential. But what arguably, yes, there are osteoblasts, but are the osteoblasts the predominant component here? And what else might you think of with this kind of loose fibrous background with some maybe red cells here and there?
Something related to the patient clinical history.
So CLL and TTC. Anybody else have any other things to consider on the differential diagnosis? There is fibrous dysplasia. Okay. So fibrous dysplasia would be something to consider with the bone deposition. Generally, fibrous dysplasia doesn't have osteoblast rimming and doesn't have giant cell osteoclast deposition. So if you were to see these osteoid spicules with a very, very paucicellular background without osteoclast, without osteoblasts? Sure. But in this case, these cells are going to kind of push me away from fibrous dysplasia. There are vessels in the background. Why some of you are saying vascular tumors. Usually vascular tumors don't make bone. All right. So usually vascular tumors infiltrate between pre-existing lamellar bone. And in fact, we can see that this is not lamellar bone, right? We think that this bone might be being formed by the tumor. And so unfortunately, I don't think a vascular tumor is quite as high in this case for that reason. Somebody said, angiomyxoma. Yeah, I don't know where that's coming from. Paget's, ABC, vascular angiofibroma. Yeah, we have to think about things that can form bone, right? So osteosarcoma is definitely one of them. But do you see the malignant appearing background cells being like enlarged, hyperchromatic, mitotically active? I would argue not really, right? I agree with Heather. So there's one maybe tiny extra clue. Yeah, malignant osteoid, so would be very lacy, would be entrapping malignant cells, right? By definition, that's malignant osteoid. So there's two things here on this other piece of tissue that actually I think are a little more helpful. So if you look at this tiny little piece of tissue, one, we see blood, all right? And two, we see almost like a little, I'm sorry that this part of the scan is a little blurry. Yeah, we see a little tissue lined by these cells with a little giant cell jumping off, right? And then this lining here again. And so don't forget jumping ship cells, lemmings. So don't forget that here it's a little more in focus, right? Don't forget that aneurysmal bone cysts can be solid, okay, and can make bone. So the two things that were top of our differential diagnosis were osteoblastoma and aneurysmal bone cysts. And so you may see on the left here that I have an immunohistochemical stain that Heather took a picture of for FOSB. Anybody know what FOSB is and why we might have done it? So this is a newer marker of mutation in osteoblastomas that are thought to have FOSB mutations and would express FOSB in the nucleus of the vast majority of the cells. So this is a FOSB in that fibrocellular area. If positive, it would suggest osteoblastoma, but in this case, it's negative. And yes, this did have a USP6 gene rearrangement on fish. So this is a predominantly solid aneurysmal bone cyst presenting in an odd location that's more expected for osteoblastoma. And so we use the immunostain and the genetic test to help us differentiate in this one. But don't forget that in the solid mural portions of ABC, you can get osteoid production like this. And so you really have to look around for other features that are suggestive, as in this case, that little guy jumping out into on MRI, you'd see a fluid levels that would correspond to different ages of blood, right? Even the radiology in this case was not clear, right? So which is why we had to pursue all the molecular testing, because neither the radiology nor the histology was perfect. Yes, and if it's a solid ABC, it wouldn't have the cysts and it wouldn't really have a fluid levels, right? What else was I gonna say? Is there anything, any other differentials I didn't really address? Okay. All right. Next. 65-year-old male with pathologic right femoral fracture due to large heterogeneous mass.
So I included this one because this is easily the most impressive pathologic fracture I've ever seen in my life. On the left, I don't think I need to point that out for you. And the lesion is this big sort of heterogeneous thing that you can see here on T1 that's sort of iso-intense to muscle. And it does have kind of patchy areas of enhancement and central necrosis. You can't really straight up make a diagnosis of anything based on these features except to say that it's bad.
It's bad. All right. So an old guy.
This is bad.
An old guy with a fracture due to this gigantic mass outside of his bone, right? So the mass isn't necessarily arising from the bone, it's just pushing on the bone and causing it to crack. So, yeah. All right, somebody new want to describe?
I can describe.
Thank you.
Seems like a lot's going on. Most of it looks bad. But yeah, it's variably, but generally cellular. Lot of just like very, very atypical cells. Some of them are, I mean, they're different flavors too. Like some of them are like a little spindly and eosinophilic, and some, like in this area, are very large and multivaculated. They don't quite look like lipoblasts or brown fat, but like those are a couple of things that come to mind for those types of cells. I don't know, like just it's very weird looking. Yeah.
So benign or malignant?
Malignant. Even if just by mass effect malignant.
Right.
So, yeah, it's not. Yeah, so like I mean, it's like even worse than what I've seen so far for like liposarc, like a very not differentiated, well differentiated liposarc. But yeah, definitely some of those atypical cells, and it's like not the location you usually think of for that too, but some other sarcoma too.
Yeah. So we have a deep tumor that is composed of these very bizarre, I would just call them bizarre looking cells, right? With prominent nucleoli, with multinucleation, with weird vacuoles. I honestly haven't seen mitoses, but the cytology here is just too bad to be benign. Yeah, I don't think this was a bone met. I think this was just a periosseous tumor compressing the bone and causing it to crack. Right. This is a primary soft tissue tumor that caused osseous fracture. Yep, mass effect. And so we also, what else do we see? We see some kind of maybe background neutrophils with some kind of karyorectic debris and maybe degenerative looking change. And so, you know, I think you can throw the book at this. You can throw the immunohistochemical book at this. And unfortunately, like probably nothing is going to help you, but you have to exclude things like some kind of balloon cell melanoma, maybe some kind of weird carcinoma, S100 for lipoblasts. So, you know, S100 doesn't really necessarily stain the malignant liposarcomas. It'll stain benign fat, but it's not as reliable in like pleomorphic liposarc, D. diff liposarc. So I wouldn't use S100 alone to determine what are the, if you're thinking liposarc, because I see a lot of you've already mentioned that, what are the, I'm going to type in the text, what are the basically three main like buckets of liposarcoma that you have to consider? So somebody I think already wrote pleomorphic liposarc. Okay. And what is MDM2 CDK4 going to help you with?
It wouldn't help. Those are well differentiated.
And
right?
And D. diff, right? So well diff, D. diff would be MDM2 CDK4. Okay. And what's the third kind? Third kind of liposarc?
DIT3 rearrangement, but this is for
okay.
myxoid maybe.
Okay, right, myxoid round cell. So does pleomorphic liposarc have any specific genetics?
I think
No.
no.
No, right? Just complex karyotype. All right. So yes, well-differentiated liposarcoma, or correctly in the extremities, would be called atypical lipomatous tumor. Atypical lipomatous tumor / well-diff liposarc can transform, right, to D-diff liposarc high-grade bad, which would retain MDM2 CDK4 amplification. Okay. Mixoid would be the low-grade variant, which transforms to round cell, which both would retain the DDIT3 rearrangement. And again, pleomorphic has no low-grade precursor. It's just a bad high grade. So well-diff is the low grade, D-diff is the high grade, mixoid is the low grade, round cell is the high grade, pleomorphic just high grade, no genetics. Okay. So once you have those 3 buckets in mind, there are potentially 2 that this could fit into based on the possibility of these being lipoblasts. But I'm going to urge you to look carefully at the morphology of these cells and tell me if you really think these are pleomorphic lipoblasts or not. You can say yes or no in the chat if you want. Yes, pleomorphic lipoblast, no pleomorphic lipoblast, and why. Two yeses and one no. Okay, so Heather Smith, tell us about the morphology of pleomorphic lipoblast.
I mean, I guess typically for any lipoblast, I would expect to see fat vacuoles that are actually like indenting the nucleus, and I don't really see that here. I just see like big ugly nuclei with big ugly pseudo-inclusions. I don't really see like the indentation of the nucleus by the fat vacuoles that you would expect for a true lipoblast.
Exactly. So there's foamy cytoplasm, and the foamy cytoplasm is microvaculated, right? Usually the fat of a pleomorphic lipoblast is more kind of maybe this size, like a little bit larger, not so finely micro, and indents the nucleus, right? So by definition, a lipoblast, regardless of whether it's a signet ring, right, which is going to be like your nucleus is indented on one side, right? It's being pushed over by the fat vacuole, or whether your lipoblasts is like bivacuolated, right? In either case, it's going to squash the nucleus such that your nucleus is either squashed on one side if it's signet ring, on two sides if it's bivacuolated, and if it's a pleomorphic lipoblast, on multiple sides by the multiple fat vacuoles, right? So your pleomorphic lipoblasts absolutely should have nuclei that are indented by the vacuoles rather than that are pushing the vacuoles aside. So that's the same concept that we see here, right? We see small vacuoles with the nuclei being plump and not compressed. And so nuclei being plump and not compressed, to me, does not indicate a true lipoblaст. But that is certainly what you have to consider. This type of picture, I'm not saying that this what this is at all, but this type of morphology with the nucleus being round and plump and not indented is also what you see, and I think somebody mentioned it, brown fat, right? So brown fat also has small vacuoles and the nucleus is not indented, okay? So just, I don't think this is brown fat, and there really isn't a great brown fat malignant equivalent. So I think these are just foamy tumor cells. And so, like we said, a foam cell or a balloon cell melanoma, S100 SOX10. If you are thinking that these are, I'm going to show you the resection now. If you are thinking that these are, I think this was treated, so the morphology might be a little bit different. But again, that same picture is recapitulated where the nucleus is plump and is not indented by, oh, there's a nice mitotic figure, is not indented by those vacuoles. And so we know that in post-treatment sarcomas, sometimes the morphology can change, but in this case, it actually kind of maintained that very bizarre look with these very fine cytoplasmic vacuoles. The one thing I will mention is that if you truly do have lipoblast with, you know, indented nuclei, what are the two differentials that could be, right? You can still be a pleomorphic liposarcoma, but what else could this be? If you had true pleomorphic lipoblast. All right, this could be a pleomorphic liposarcoma-like area of a dedifferentiated liposarcoma. Okay. And in this case, what's going to be your genetics? Right now we have the MDM2 CDK4, right? So true pleomorphic lipoblasts can be seen in pleomorphic liposarc, complex nonspecific karyotype, and pleomorphic liposarcoma like areas of a D diff. So you always want to do the MDM2 if you think you see true lipoblasts. In this case, I believe the MDM2 CDK4 were done, and they were still negative because this isn't that. Okay. Yeah, pleomorphic lipoma, certainly, but again, you wouldn't expect bizarre, you wouldn't expect hyperchromatic. You would have other things like shredded collagen, like your rosette type of cells, not this location, not this necrotic, not this mitotically active, all that good stuff. Not a cracking of femur, right? Exactly. So hopefully so we ended up calling this on the final resection just an undifferentiated sarcoma, right? So once you've excluded everything, you've excluded all your types of differentiated sarcomas, you're basically left with a bizarre undifferentiated sarcoma, right? Formerly called undifferentiated pleomorphic sarcoma, formerly called malignant fibrous histiocytoma, now just undifferentiated sarcoma. Questions? Ooh, this looks like the frozen room. Hold on a second. Okay, they want me to look at a frozen. Do you guys want to continue this case with Heather, or do you want to look at the frozen?
Doesn't matter. We can see the frozen. Why not? We can try to help you. Oh God. Okay. Sure.
All right, then you guys have the link to the LV1 meeting, right?
Yeah, we can just switch over there.
Yeah. All right, you can see that?
Yep.
Good. So, all right, in the last couple minutes, we'll do the last case real quick. 49-year-old male with large posterior thigh mass. I'll just let you all take a look at it. If you were to give these cells a few descriptive words, what would they be?
Like small round blue cell, kind of plasmacytoid also.
Mm-hmm. Yeah, kind of plump, kind of round in areas, kind of plasmacytoid or rhabdoid, right? Like not super spindly, but kind of plump and round. Vascular lesion was brought up. You know, I don't see true vasoformative spaces, and I don't see red cells, so that makes vascular a little bit less on my differential. I do see some hyperchromatic cells and mitoses. I see some background stromal material. I think this is a little bit of a hard one. In fact, Anybody else want to throw any differentials out and we can talk through them? Otherwise, I'll talk through my thoughts on this. Melanoma with that plasmacytoid appearance, certainly S100 SOX10 you could do with the large nucleoli. In this case, it would be negative. If you still were thinking vascular, right? CD31, 34, ERG, probably negative. What else with this round, right? If you're saying small round blue cell or at least round cell morphology, what types of tumors have round cell morphology? Ewing, MM meaning malignant melanoma or something else? Multiple myeloma?
Yeah, I guess a
Yes.
plasmacytoma kind of.
Yes, multiple myeloma or plasmacytoma, yeah.
Okay. What else did we just talk about?
Round cell lipoma. I
Well,
mean,
liposarcoma, right? What else? Yes, we already said Ewing's PNET. We already had a desmoplastic small round. So this is a little old for desmoplastic, but adults can get Ewing PNET. No worries. All right, so in this case, well, CD99, Fly1 for Ewing's might be what you want. Although, you know, those aren't always 100% specific because you can have some immunohistochemical overlap. Genetics, arguably for Ewing's, are very specific. And in this case, EWSR rearrangement was performed and it was negative. All right. So not a Ewing's. Stains for plasma cell neoplasm were bad. Stains for round cell liposarc, really, well, there aren't any. You'd have to do the genetics for there as well. But there's actually one round cell variant of a sarcoma that we're not talking about yet. So if you want, I'll give it away. You probably see it on the bottom here already. So this is an immunostain for EMA, which is pretty strong in those round tumor cells. And this is an immunostain for TLE1. So what am I hinting at?
synovial sarcoma. I guess, you know, you can also see from the sidebar here too.
Exactly. So this had the SS18 gene rearrangement and is in fact a synovial sarcoma. So, you know, don't forget to sort of cast a broad net when things that you think it might be fail, because often you can come to a definite diagnosis. You know, in the prior case, we couldn't come to a definite diagnosis, so we had to just say undifferentiated sarcoma, right? We couldn't put it in a box. In this case, we could put it in a box based on that round cell morphology. This is a round cell variant of synovial sarcoma, at least on the biopsy. So just remember that that exists. Remember that for synovial sarc, you should have some kind of keratin or EMA, and you should have TLE1. The other thing I will say is that, you know, TLE1 is not excellent for this diagnosis. TLE1 can stain a lot of things, including other sarcomas, sarcomatoid carcinomas. So just my caveat is to use TLE1 with caution. Only consider synovial sarc if you have a good morphology and a keratin or an EMA, and always confirm with the genetics. Okay, always, always, always. This is the resection from that synovial sarc. And interestingly, on the resection, we see more areas that are much more classic spindled, right? Classic kind of interlacing fascicles of relatively kind of monotonous spindle cells with these small nucleoli with a little bit of collagen in the background. So just remember that, you know, tumors can take on varying morphologies. Synovial is one of them that can be a little bit of a challenge if you have round cell morphology and don't necessarily think about it on your differential. So here's an example of maybe an area that's getting a little more like the biopsy with a lot of stroma with a lot more round cells. And then as you move along, you get a little bit less stroma and a little bit more spindle cells, which is more classic synovial sarc morphology, right? So just an interesting example of a classic diagnosis, but a variant morphology, okay? Anything else?
No, it doesn't seem like it. Thanks for finishing this up.
Yeah, thank you guys.
Thank you.